You go.
All right. Well, I think, for those of you who may not know me, I'm Maria Abreu. I'm a gastroenterologist on the faculty and proud to be vice chair for research in the Department of Medicine. And as you know, the year in research builds up to Research Day, and it's a very special day where we try not only to show off what we do, but also inspire the next generation of people who will carry the torch for doing research, whether it's clinical research or basic research. We had some absolutely fabulous workshops this morning on healthcare advocacy and doing research in disparities. And I think that that's befitting our Grand Round speaker. Dr. James MADARA has had multiple very successful lives. In the first life that I knew Jim MADARA, he was my research idol. He is a physician scientist. He's a GI pathologist. In fact, founded the division of GI pathology at the Brigham when I was a house officer there. I was going to say a nobody, but still am a nobody. And during that time, you may be aware that becoming a full professor in the Harvard system is nearly impossible, and he had a meteoric rise to be a full professor of pathology in a very short period of time. After that, he went to Emory to be chair of pathology, so he had that leadership. And ultimately, he went to the University of Chicago, where he was dean of the medical school, dean of biological sciences, and CEO of the medical system. All of that has, of course, prepared him to take on this role as CEO of the American Medical Association during an incredibly difficult time in American medicine. I think probably you can always say that, but I think there's validity in that statement of the complexity of the things that we have to navigate in our health system now. And it's fair to say he's witnessed this explosion in technology, having a COVID pandemic, and the acceleration of all the things that are downstream of changing the way we deliver care. And so with that as a backdrop, I am really so excited to welcome Jim to us. As I joked before you guys came on, he's talking to us, I think, from Chicago, and chose because of all the commitments he has at such a high level, we understand that he couldn't be here in person, but I know he will impart amazing wisdom to us nonetheless. Thank you so much for doing this, Jim.
Well, thanks very much for that introduction. I should say that, I got to know Dr. Abreu probably first at the Brigham when she was in internal medicine, and then probably through her subsequent training at UCLA, and then beyond that. And at my time in Chicago, I was just really lucky to have Roy Weiss as a senior member and leader in the faculty. And, he took over a GCRC unit from the NIH and turned that around. I noticed in your titles, Roy, that you are also, among other things, the Morris S. Formes Professor. And Morris F. Formes, in recognition of Roy, also had an endowed professorship at University of Chicago. And one of the things we'll both remember about it is that in the creation of this, we had a ceremony, and Morris F. Formes' 5 minutes to give comments turned into about 65. I'm sure Roy remembers that. But it's really wonderful and an honor to be invited for this Grand Rounds. And I thought what I would do is talk about what we're doing at the AMA, because that conveys how we're thinking about the future of medicine by the actions that we're taking. So I thought I would take that point of view in talking about the future of medicine. Disclosures, no personal financial interest in this subject matter. I am the board chair of Health 2047, which is an independently operating subsidiary for-profit of the AMA, but I have no personal financial benefit there. The objectives is really to introduce the AMA strategic framework. It's been simplified, as you'll see, and indicates what we're going to do, and then take you through some examples of work done within this framework. The other important point is that you'll see that the work that we do attends to pre-competitive needs. And what I mean by that is we select problems that need some attention and some solutions, but they're problems of a particular kind, the kind that it doesn't really matter what health system we have in mid-century. If we don't have these things partially solved, no health system is going to work very well. So that's the idea of a pre-competitive need. And in terms of innovation, you also see that we pay a lot of attention to defining the problem on a particular site. Most of our solutions and products that we have start with problem definition at the administrative level, and then the solution is thrown over the transom into the patient-physician realm. And a lot of those things are point solutions that don't work very well down there. And so we think the truth of the healthcare system is at the physician-patient interface, not at the administrative site. So another way of saying this, the way a lot of our products currently are made is we define a problem at the administrative level and deal with it from there. And that would be the same as General Motors paying attention only to the dealership and not really caring a whit about the driver or the mechanic. And so we have to flip this around a bit. This is our mission statement: promote the art and science of medicine, the betterment of public health. I have to admit, when I was called, I wouldn't have guessed this was our mission statement. And there were two things that actually attracted me to this. And that is the search committee didn't like the way AMA did strategy. They wanted to see if there was a different way of doing strategy. And they wanted this mission statement to come more to life. And so those were the two things that attracted me, I have to say. And to begin understanding, I made this slide for my sister when I took the job, who wanted to know what the AMA was, and I had to explain to her what it was, and I needed some template to do that. And there are multiple pieces of the AMA. Now, the second block, members in blue, is how everyone thinks of the AMA, and we have about 275,000 direct members, and they're members for a variety of reasons. Some of them, if they're not an institution, is to get JAMA and any other business products, et cetera, and we can talk about that. But if you look to the far left, there's also a House of Delegates. And whereas the second block, members, characterizes us as a membership organization, the House of Delegates characterizes us as an organization of organizations. And what's represented in the House of Delegates, which is a debating body that approves the policy of the AMA, it's all state societies. It's all branches of military medicine. It's all national specialty societies. It's 185 societies, things that you would recognize, like the American College of Cardiology, and things you would have no idea of ever hearing about, probably, like the Society of Underwater Medicine. So it's all of these societies making the policy, and they represent far more than 90% of the physicians. And that's why the policy of the AMA has special heft in DC, because it's not just these members, it's actually the organization of organizations view of how the policy is produced. And then moving to the right, we have practice and business tools. I just mentioned a few of them. We shepherd the CPT coding system for the nation, the physician master file, where every physician has a number signed when he or she first enters medical school, and that number resides with them until death. And that's an important national product. USAN is we name the generic drugs. RUC, we assign values to the procedural codes. We have an insurance brokerage. We publish the guides to permanent impairment. used for disability. So there are a lot of various business tools and practice tools that we have. And then research and education, you know about JAM and the JAMA network. Most institutions use the AMA Code of Medical Ethics. And then we have what was developed after I got here as the strategic platform, which I'll introduce, and is composed of 3 ARCs and 3 accelerators. And then lastly, we have advocacy in DC, in the states, and in the courts. There's an innovation ecosystem under these 3 components that I'll outline. And you'll see our major office is in Chicago. This is the AMA Plaza building. We have the name, but we occupy only about the top 10 floors. We have a venture creation and corporate spin-out enterprise in Menlo Park, right on Sand Hill Road, Health 2047. And of course, we have offices in DC, close to the Capitol, for our advocacy group. So in coming to the organization, we did an audit of the projects that existed, and there were 110 of them. And that was too many to deal with, so we could sort of push some together and set 27 domains. It wasn't that bad to have a lot of different projects. What was bad about it, though, was that these were not connected one to another. There was no intellectual cohesion. So that you'll see that we started out creating a strategic platform that simplified this. Each of those elements has also arborized, but in a way that has intellectual cohesion to it, as you'll see. And so there are some things that you'll see, like the lower left quadrant. One of those is disaster medicine. We had a disaster medicine section. We had a disaster medicine journal. But if you go out in the street and ask the first 5 people we see, name 5 organizations important in national disasters, probably no one would have said the AMA. So we redeployed those resources, and we did that again and again. And after about 8 months of work, we simplified it to this strategic framework that you see here. And the problem that, how could you have a concentrated strategy if you have the House of Delegates making policy twice a year? The answer to that was looking at the policy portfolio and recognizing that there were meta signals in there. There were themes that had 30, 40, 50 policies underlying them. So those you could be confident in as areas of focus. And so the inner circle here are these 3 strategic arcs that came out of that. Chronic disease takes up almost 90% of our $4 trillion healthcare spend. We're not doing well in chronic disease. And we're still, if anything, structured, tilted more toward episodic disease than we are chronic in our health system. Professional development, we have, for example, with every new finding and every new discovery, we put that on our educational Christmas tree. But the basic structure of that education has not changed in 75 years. And how do we think about lifelong development, lifelong learning when we shift from less memorization to more knowledge control? And removing obstacles, we ended up doing a study to see what satisfied physicians with RAND early on. And the number 1 satisfier for physicians, in fact, the number 1, 2, and 3 satisfier was focused face time with patients. And all the dissatisfiers were things that got in the way of that. The structure of the ESR, of the EMR at the time, all these administrative things. And so if that's what satisfies physicians, how do physicians spend their time? So we did a time motion study, again, multiple markets. And we learned in this study that has been widely cited that for every hour, which is the satisfying part, that a physician spends face-to-face with a patient, there are about 2 hours administrivia. And that didn't count, since we didn't measure it at night, that didn't count the 1 or 2 hours at night that people spend, logging in and data entry and whatnot. So no wonder things were in a bad state, and we want to get through to return more time to physicians. So those are the 3 strategic arcs of the AMA. And then about 5 years ago, as this work went on, we realized that there were accelerators for all 3 of these that were shared. One accelerator was health equity. With the inequities that occur in our health system, there were like an artificial glass ceiling on progress in all 3 of these arcs. I'll talk about that. There's advocacy as a way of memorializing progress through regulation and legislation. And there's innovation. So what I'm going to do is just give some examples of the work in the cross-enterprise accelerators, innovation, advocacy, equity, and then give some examples of the work in chronic disease, professional development. But in starting with these accelerators, I'll touch on how, for example, innovation touches each of these arcs, and do the same for equity and advocacy. So going to the innovation ecosystem and talking with the accelerator of innovation first, we created an environmental intelligence unit, which sometimes interfaces with some of the well-known management consulting firms to have a good view of what was going on out there, what the market needed, and what was happening nationally. And we found that we could do low to moderate tech solutions for the 3 strategic arcs using innovation in our major facilities. But for high-tech solutions, we needed probably another approach, which I'll mention. I already mentioned defining the problem at the right site. MADARA is a state, city, and multi-institutional venture development shop here in Chicago. I'm on the board, but we don't control MADARA. We're just a participant. It's spun out about 200 startups. We have an AMA interactive lab there that can help define physician-oriented problems. And we make sure that physicians that are entrepreneurs begin defining problems at the right level again. I'll talk a little bit about Health 2047, which we created 5 years ago, or 6 years ago, for more complex technical solutions. And then in terms of funding for companies that we formed that spin out, we developed a fund, Health 2047 Capital Partners. And we have alignment here. So we went through the strategic arcs of the AMA. The strategic pillars of Health 2047 are the commercial translation of those arcs. And then Capital Partners has the guidelines, guide rails for investment theses reflecting the pillars of Health 2047 that reflect the arcs of the AMA. So that's the organization through this. And on the right, just a couple of things about Health 2047. In creating an innovation shop, I looked around at some of the innovation shops that are very common in our institutions. And what I found is that most of them had 3 problems, it seemed to me. The first problem was governance. They were not independently operating. And they weren't often for profit. So they wouldn't reflect, the pull that you get for real entrepreneurs. Keeping the innovation shop under the governance of the organization squelches, in part, by bureaucracy, the flexibility of that organization. A ridiculous way to put this, is institutions, they love the innovation shops, but they pet the gerbil till it dies. The second problem was the problem definitions. Even if institutions in general if you identify the problem at the right site, say patient physician, you tend to start playing small ball, number one. And if you do produce a product, it's often not very flexible and therefore bespoke to the organization. And the third limitation is that these tend to be on the site of the university, and the universities are not always on the site that are really richly surrounded by coders, engineers, behavioral psychologists, and all the people that you need in venture development. So I ran into the person who did the program development for something called In-Q-Tel at the Central Intelligence Agency, and it sounded exactly right. And so we kind of copied their homework. Now, one of the things, this was founded in the late 90s, so you could have a sense of the track record. And one of the aspects of the In-Q-Tel CIA relationship that I heard about is that it can be rough at the interface for a while. And I would say that we struggled for about 18 months until we got a really good working interface between the subject matter experts and all the healthcare microverticals in Chicago and the entrepreneurs on the West Coast. They're very different cultures, and you have to work hard at that interface. So innovation touches a lot of the elements of the strategic framework, and I already talked about the alignment here on the left, the strategic arcs of the AMA, the pillars of the 2047 that are the commercial translation of those, and then the capital partners investment theses guide rails. And in terms of examples, I'll just name a couple of them here, and how they touch the three strategic arcs. In the professional development arc, I'll mention in the Ed Hub, where there had to be some joint work on that. It's a digital education platform. There's a tool called Reconnect that's out in its alpha form right now in the wild at institutions, 2 or 3 institutions. And what Reconnect is a AI-driven tool that can go into the EHR of a physician's panel, interrogate that panel, and then conclude what it is that physician actually sees in her practice. And from that, create a bespoke educational platform to try to get her away from this physician education box checking thing, where everyone has to do the same thing. And one of the things we learned in doing the groundwork for this is, physicians sometimes don't like what they go through to re-credential. And it's because you'll have a psychiatrist, say, who has never written a script for an opioid, and yet has to do the opioid educational module. What we found is that if you present physicians educational product that they intrinsically feel relates to the reality of their practice, they just gobble it up. They're just looking for that. So there's a couple of examples of innovation in the arc of professional development. In chronic disease, I'll show a couple of things related to hypertension and hypertension control. And the idea of these things knitted together is that eventually you have home blood pressures taken. You have, verification that it's a validated cuff. You have verification from the patient that all the positioning was the correct positioning for a correct blood pressure. You can then load that to the cloud, download that to the EHR, and extract from that a physician's panel of blood pressure control. And I'll show some examples of that. So an example in chronic disease of innovation. And in terms of removing obstacles to patient care, both data and digital tools, I'll just briefly touch on data organization. So we have, as some people would say, oceans and oceans of data, but just little puddles of actually information to make this more useful and friendly to physicians. And AI is going to play a large part of that. And by that, I mean less artificial intelligence and more augmented intelligence. And this just shows that, a series of the companies that have spun out from Health 2047, align with our mission and how. The Health 2047 and the Innovation Shop has been recognized here. CB Insights provides to the corporate world data and analyses related to healthcare development. And they last year presented their top 27 corporate innovation labs. And we were delighted to be the second, number 2. We would have rather been number 1, that Novartis Microsoft AI Innovation Lab took over that position. So it's being recognized now publicly. So that was the accelerator of innovation. How about the accelerator of advocacy and how it touches these arcs, these strategic arcs? Some example, professional development and advocacy is toward less rigid timeframes. I'll mention something about incompetency-based education in medical school. Why does it have to be 4 years? If someone's ready in 3 or 3.5. And there are examples of schools in our consortium that are doing that. And that, of course, required some regulatory relief from LCME. We're one of the parent organizations of LCME that helped there. Chronic disease, an example is we had an interest in diabetes prevention programs in our chronic disease arc. But part of the problem is, if the dollars don't follow the programs don't happen. And there was no reimbursement for diabetes prevention programs. We worked in our own area and identified a program, a diabetes prevention program that when applied, seemingly would save money. And we used Avalier as a company to show that. I talked the Centers for Medicare and Medicaid Services into agreeing that this was interesting. They took it to the CBO. It was scored positively, and that resulted in the regulators allowing Medicare and then eventually Medicaid reimbursement. So it shows an example of the memorialization through advocacy of the progress. And removing obstacles, working with the Office of National Coordinator toward the new rules of outlawing, so to speak, data blocking. I'll show you an example of dashboards for common disease. We also work to allow the restrictions that were pre-pandemic on telemedicine to be relaxed in this coming up post-pandemic period. You'll recall the shift to telemedicine during the pandemic. And if you looked at it, it's a variety of institutions. If you're doing venture, what you like to have is sort of a 10x change. And between December of 2019 and May of 2020, use of telemedicine in institutions was not a 10x change. It was anywhere from a 30 to 100x change. It was really remarkable, and we want to keep some of those flexibilities so it can be used the correct way. And equity as the third cross-enterprise accelerator for the 3 arcs. Professional development arc, the work on health, on cultural competency. We created with our consortium, the 3rd science of medical school, clinical science, basic science, and health system science, which includes things ranging from cultural competency to data analytics. And chronic disease, our equity work showed, as I'll demonstrate in Cook County, a positive effect on underserved communities. West Side United is a group effort of which we're a part, but includes institutions, including Lurie Children's, Rush, the Rush Medical System, Northern Trust Bank, many community organizations. And the metric that we're going to use over the next decade is the metric of life expectancy. Where I'm sitting in downtown Chicago, our life expectancy is 16 years longer than it is in the West Side, just 6 miles to the west. So how can we get that to a 15-year, 14-year, 12, 10-year difference? And removing obstacles, we've done this through various means, including a couple campaigns, public service announcements with the Ad Council for COVID vaccine issue during the pandemic, and now with the Ad Council and the American Heart Association for recognition of the problem of uncontrolled high blood pressure. Another equity effort that's just launching, the soft launch was a couple of months ago. The hard launch, I think, is next month, is a Rise to Health Coalition. And this kind of takes a lot of the thought that went into the medical school consortium, where we would have, a variety of medical schools participate in a consortium, share innovations, who was doing what, learn from each other, and pair up some medical schools that were working on common themes. This is the same thing with equity. Everyone's doing experimentation on equity, but no one's sharing that data. So we're sort of having this coalition to come together and share what everyone is doing in the area of equity and learn and see if there are institutions that are having the same question and effort around equity that should be brought together as an experimental group. And these are just a few, and we now have a lot of medical institutions joining this as well. So those are the 3 accelerators: innovation, advocacy, and equity. And now just some examples of the arcs themselves, the 3 arcs themselves. Professional development arc. We began with medical schools. And now you'll see that's moved on to residency considerations. At the same time, lifelong learning platforms. So we started with actually 15, but now we have 37 medical schools in this consortium. And we wanted to make sure that we had research intensive schools like, Harvard, UCSF, Chicago, but also community oriented schools like East Carolina and Dell, and also some osteopathic schools. I think we have 2 or 3. They come together a couple times a year. They work on joint projects. The joint there may be 4 of these with a similar interest. And from this work in the last, say, 8 years has come out health system science, which is now embedded in many of these schools and many outside, has a curriculum developed. The second issue of the text for health system science has just been released. Competency-based medical education. So if you look at a school like Oregon, as part of that group, they're now graduating a fair number of their students in less than 4 years. The students face less tuition. And, why does everyone have to sit in the chair or in their apartment, for the same 4 years? So a variety of innovations like that. And those have been published. This cost us only about $14 million to get these 37 medical schools interacting. So today, that funding supports 23,000 medical students. And if you do the arithmetic on the average panel, they'll provide care for more than 40 million people annually in the future. We've also enriched the interaction in sort of the network growth of publishing around medical school education. And you can see in the upper left, what our network looked like in 2014 of academic publications in this area. And in the lower right, what it looks like in 2018 and 2022, it kind of looks like one black smear in it now, more or less. So now that led to a more recent program, and that's reimagining residency. So moving from staying with the medical school consortium, and we, proposed that we would give grants to initiate transformation of residency programs. We put out an RFP and we got over 250 letters of application. And we selected about 10 or 11 of these program projects that were submitted. And these are the 11, 8 funded and 3 planning grants. And I'll just highlight, I put one in red just to highlight the kind of thing. And they all have very different ideas about reimagining residency and different aspects of it. But the one that was submitted by Hopkins, Stanford, and Alabama had to do with the question of how do we know our residents are spending time getting educated? That's what residency is for. So again, we did time motion studies in residents, beginning with Hopkins. And we found that if we think of education as direct interaction with patients and the conversation around that, plus educational domains like grand rounds and whatnot, when you're actively moving around the hospital, how much of your time do you spend in the educational domain? And the answer is less than 50%. So the question is, how do you restructure this so you can get more time with raw educational experiences rather than the administrivia that sometimes residents are burdened with? And all of these associations, all of these RFPs have a specific area of focus in reimagining residency. So then in terms of lifelong learning, to go along with the work that we did here, we developed a digital education hub for information that comes from JAMA, JAMA Network, all the units, specialty units within the AMA. But we took about 3 years to develop this because I wanted the digital backbone to be attractive enough that other organizations would want to actually use it as well. And I think we've gotten there. We now have a variety of organizations of various types that use our backbone, and they can be anything from universities like Stanford to in the genomics domain, the Jackson Lab. We now have, I think, something like 20 societies. The first one was American College of Radiology using this backbone. So it seems to be attractive to others, which was what our wish was, to load this up so that you can start imagining the Venn diagram intersection with, say, the Reconnect tool that's going to give a bespoke educational program for the physician to a data-rich digital platform. CDC also selected our education hub for their new program in training healthcare professionals in infection control, a need that came for, to the front during the pandemic. So that's a taste of professional development, a taste of chronic disease arc. Well, we've spent a lot of time in hypertension, choosing it because it's the #1 cause of death and disability in the United States. And about 100 million people have high blood pressure in our country. And about half of it is uncontrolled, even those seeing providers. If you go to a standard practice, about 50% of your hypertensives will be under control. And the rate is even more accentuated in minority populations. Again, it's the #1 modifiable risk factor for cardiovascular events. And our first recognition of this study was that people don't measure blood pressure properly. It's not always a validated cuff. And to get a proper measure of blood pressure, the patient has to be in a relaxed state for 5 to 10 minutes, bladder empty, not smoking recently, sitting on a chair, feet flat on the floor, back supported. Also need to have the cuff go on skin, not on cloth, with the arm supported at 90 degrees. That's not typically what happens in our clinics. Each of those things, if off, increase blood pressure a couple million meters of mercury. So the first was accurate measurement. And then we looked for ways of making this simpler for physicians. And this was from pilot work down in the Carolinas with a few practices. And what we found is if we create a dashboard like is shown here, and this is another AI-driven tool that goes into the EHR to get this data out and then organize, and we allowed physicians to sculpt this for us, how they wanted to see the data. And you see in this particular practice, the control is about 70%, 71%. It was 50% at the start of this exercise, like most typically blood pressures are. And it was just providing this tool and some conversation with the employees of the physician's office, that allowed this go from 50 to 70% without much effort. And that 20% increase in control would translate into, if you look at the literature, a significant decrease in cardiovascular and stroke events. And, as I pointed out, the use of this tool increases blood pressure control in patients. And this is now in several institutions. We also have a recognition program for control, and it was a 2019 gold status. If you were above 70%, we now have a platinum that's if you're above 80%, and we now have the participants, and you'll see here probably in 1600 now over 3,000, and as a way of recognizing the status. I'm told by my friends at the Joint Commission that they will be thinking about this as well. I won't go into the detail here, but our engineers have created another tool that basically does the following. That if you use this tool at home, it will verify whether or not you have a validated blood pressure cuff to begin with. And we work with NORC at University of Chicago to create the infrastructure so we could have the validated device list that people could access. The other thing that it will do with patient affirmation is that all those conditions that were met, bladder was empty, sitting with back support and whatnot. And then there is the electronics of taking the blood pressure, multiple blood pressures. There's a way of scrubbing signal from noise. And then it can be through Bluetooth uploaded to the cloud, and then through APIs downloaded into EHRs. And what we're working on now, this is again in alpha form, out at selected sites. Being tested now. The next phase will be to make sure that through that dashboard that I showed, the tool that does that dashboard in the last slide, that you can then also extract these new data into the EHR, into the dashboard, because it's known that the home blood pressures well taken are much more informative than the clinic blood pressures, due to the white coat phenomena and all these other things that affect blood pressure.
Wow. Hey, good job.
He's good enough.
Well,
Yeah, we had
I
it.
think
We'll work together.
there are some folks that don't have their mute on, so we hear your conversations. And we've also done this in a community.
Looks good.
Healthy pumpkin heart. Keep going.
Darian, can you please
Great job.
mute Alonso? Thank you.
Okay, great
Thanks,
job.
thanks very much. Anyway, to show this at a
Thank
level,
you. I'll take all the
a county, this is a Cook County joint health release by the AMA. We embedded this in 11 practice sites over the pandemic, 39,000 patients, majority were minoritized. And in that difficult situation of the pandemic, we had a 13% increase in blood pressure control just by allowing these tools, the dashboards, to be utilized. So then the last thing is removing obstacles, of which there are many, as you know. It's death by 1,000 cuts when it comes to obstacles around physicians. And some new examples of this were payment linkages. Again, recognizing payment is important for integration of new programs. There were no CPT codes for vaccines, for diagnosis or evaluations during COVID, and we had to rapidly produce those. And we did digital related payment too, including telemedicine during the pandemic. So new codes that could be linked. A lot of obstacles that, could, if they could reduce regulatory, provide regulatory relief and administrative simplification. And I've named a couple of those, but some of those, relate to what I've talked about with the hypertension, like the self-measured blood pressure I mentioned on the previous slide. What we rolled out more recently, right on the tail end of the pandemic, assuming the emergency will be relieved in May, but I'm assuming that we're in the tail end here, is given what physicians went through during the pandemic, we wanted to use language that the pandemic embedded in other spheres to capture something that needed to be done for physicians. And so this was the recovery plan for America's physicians. And we put 5 elements under this, reforming Medicare payment. And the fact of this matter is, if you look at physician reimbursement for Medicare over the last 20 years, and you compare it to hospital reimbursement for Medicare over that 20-year period has tracked upward with the CPI. It's been flat for physicians. That will be devastating if it continues. Prior authorization, our studies show that for an average physician, there are 34 prior authorizations per week. And it takes up to 16 hours of someone's time to work those prior auths. Cleveland Clinic had a group of 200 people full-time just doing prior authorization. And a lot of this it's really utilization control that doesn't improve. So it's not a matter of getting rid of prior authorization. It's a matter of right sizing it, which is probably about a 90% shrinkage in prior auth. There is a bill that got sort of hung up in Congress that was bipartisan that we helped put together around prior auth, and we're continuing that now after the election, although it's a dicey period now with the campaign, election coming up. Scope creep, physician burnout, and supporting telehealth, continuing that support. So these are, the AMA recovery plan for America's physicians, and it deals with removing obstacles. I'll just mention a couple of our E-related activities in the interest of time. Our digital medicine payment advisory group, AI guide, we have a guide for use in healthcare, and we view AI more as I mentioned, augmented intelligence, not artificial intelligence, most useful in administrative processes, workflows, and some decision support, completely unuseful in making diagnosis or therapeutic decisions on its own. It's really not cognitive. It's really looking at patterns, and what you feed into it determines what you get out of it. If you look at the generative AI things in healthcare coming out recently, what you'll see is what was fed into it was not necessarily JAMA and the New England Journal. It may have been Reddit. And then in workflows, even for physicians with the generative AI, what one can start seeing is that a note that has really articulate form, really articulate sentences, are the exact right form, etc. But the critical content is often wrong. But it takes a physician 5 minutes to correct that, as opposed to 40 minutes to writing it herself. So these are the kinds of things I think we'll get there. I'll slip down to PIN, a Physician Innovation Network. We did this manually at first, and then about 4 years ago, switched to a digital platform that electronically creates sort of it's like a dating app. Physicians that have particular interests and entrepreneurs working on particular problems that relate to those interests, we create a match. There are now 18,000 folks on the Physician Innovation Network. And I'll drop down to the last point. The general guidance from all of this work and others, where you need market acceptance and code development, are critical for digital products that will remove obstacles. And the first questions are asked is the e-product, is it evidence-based? Is it validated? Is it actionable? And critically, is it connected? And then what physicians ask, do the products, do they work? Are they linked to payment of some time, reimbursement of some sort? Do they carry liability? And then in my specific practice, do they work? And so these are the critical questions, the answers of which are important in thinking about these digital tools. So putting it all together, there are pre-competitive needs for healthcare over the next half century. And what I mean by that, any healthcare system that emerges will need this. Because those systems, or that system, will not be successful if the physician workforce isn't trained for the 21st, not the 20th century. If it's more about data manipulation and access and understanding than it is about memorization, for example. Those systems will not work if we don't address the increasing burden of chronic disease. COVID just demonstrated to us that this is going to be more and more as we make advances in areas of cancer and convert once deadly illness to chronic manageable disease. We're going to a chronic disease future, and we do very poorly in this area currently. And it will not work if we don't return physicians to their patients. If that 2-to-1 administrivia to FaceTime with patients is not flipped, so it's a 1-to-2. Removing those administrative obstacles that get in the way, and there are a number of those that I mentioned. So I want to thank you. This, by the way, is we've also had interactions with NASDAQ in an area I won't go into, but Alina Friedman, the CEO, and I have gotten to know each other, and she was kind enough during the pandemic to put this up on their screen for several weeks in Times Square. So I thought this was pretty cool. Thanks very much.
Dr. Madara, I think you're pretty cool. Thank you very much for your very clear and typically methodically dissecting the situation that we're all facing here in terms of healthcare. And I really appreciate your putting all of this into perspective and educating us really about the role that the AMA plays in all of this. Before we get to questions, I just want to make sure, while we have everyone's attention, that we're so pleased with Dr. Madara. I keep calling him D. Madara because that's the way in which I remember him fondly. We still have a full schedule of events. those of you that can stay on the same Zoom link, we're going to have Dr. MADARA for another hour to answer questions and discuss various topics. And then this afternoon, our poster session, which is right outside of the Lewis Pope and the Schowinger Science Triangle, between 2 and 4 p.m., culminating in the award ceremony at 4:30 p.m. with refreshments under the tent. You'll see the big tent out there. So, and kudos to Dr. Abreu for arranging all of this, and our speakers this morning. All that's wonderful, and I'll have a chance to thank them later. So back to Dr. MADARA. So, Jim, I mean, there's so many things that one could ask about and topics one could approach. One of the things that is clearly the physician workforce as it pertains to primary care. And I understand that the AMA is only one part of this. There's the Institute of Medicines, there's the ACGME, the LCME, all these different bodies that are looking at it. But the bottom line is the number of physicians going into primary care specialties is really not slated to meet the demand that we need for moving into the future. And clearly, there are reasons for it, but one of the biggest reasons is always the financial remuneration that's given for primary care versus the more specialty related services. Now, there's still, thank goodness, altruistic individuals who are clearly dedicated to the mission of medicine and going into primary care. But my question to you is, what can the AMA do to help address this critical issue that we see in the primary care field?
Yeah, thanks, Ray. I mean, that is an issue. What we've done the last few years are create E&M coding systems that reward primary care and reimbursement through Medicare. And if you look at the distribution of Medicare dollars, it's probably not where it should be now, but there's been a heavier flow to primary care than the specialties. Of course, the specialties will say that, you know, they're shortchanged during that transaction. But the other thing I would say is thinking about where these platforms stand in medical centers. You'll recall at University of Chicago, we had no family medicine department, and the logic was, frankly, that it wasn't academic enough. So created a family medicine department, but made sure that the leadership were very academic in family medicine work. And suddenly we had, you know, our students, none of which went into family medicine. We had a whole cadre of them going into family medicine. So, you know, do we have the right mentors and, you know, attractive solutions in our own training? You know, I was, not to get off that topic, but as an example relating to this, I remember a paper I ran across many years ago where it had 2 universities that were looking at medical centers that were similar in terms of their ranking and their profile, but their graduates had a very different outcome in terms of what they selected. And it didn't seem to correlate with anything except one thing, and that was the composition of the admissions committee. The admissions committee reproduced itself. And you can imagine that if someone comes in and says to a neurosurgeon, I'm really interested in neurosurgery and, you know, neurobiology. So I think we have to think the same thing as, do we have the elevation of family medicine and primary care elevated enough in our training in our medical schools that it has the same sparkle as it should as everything else at the medical school? So a couple of things we're doing, but I agree this continues to be a problem.
Thank you. Dr. Gershengorn has her hand raised. Haley?
Yes, thanks so much, Dr. Weiss and Dr. MADARA, for a wonderful talk. One of the things that I heard sort of repeatedly throughout, both when you talked about the time motion studies for practicing physicians and also for residents, was how much of our time is spent on non-patient facing activities. And then, your really interesting exploration of sort of how you guys are trying to address that with changing codes and potential augmented intelligence with notes. The thing that I wonder though, and I don't know if this is a reasonable way to think about this, is that a lot of the solutions seem to be aimed at improving our ability to adhere to a system that's intrinsically or inherently challenging. What I mean by that is our excessive need for documentation, which in talking to colleagues around the world is very unique to the US.
Yep.
And while I very much appreciate the need for those solutions, I'm wondering, first of all, if you agree that that's an area that we need to tackle, and if that's something that the AMA is looking at, both to improve how we interact with our system, but maybe also to improve the system itself.
Yeah, I absolutely agree. And an example of that is our work around quality measures. There are a lot of quality measures that are in programs required by CMS that physicians in that specialty just don't agree that they're very meaningful. And the origin of this was the thought at CMS that you wanted to have quality measures because you wanted to give quality medicine. You want to make sure people were paying attention to that. So they would start with a small group of quality measures that everyone would agree with. A1C, hypertension, these kinds of things. But then every specialty and every subsection of that specialty needed their own quality measures. So you started getting into data that weren't very rigorous, but they, wanted quality measures for all of these things. So we had a plethora of that, and we have a dual negative effect. The first negative effect is it's too complicated. The second negative effect is the worst thing you can ask doctors to do is to do something that they think is just artificial and non-helpful and not impacting their practice. And so we have a lot of conversations around that, both at the National Academy and at CMS. But you're absolutely right, and we have a uniquely complicated healthcare system. It's not, if you look at, Australia or the Scandinavian countries during the pandemic, they were pumping out research that we couldn't match because everyone was in the system. And there was sort of uniformity in collecting the data. We have terrible interconnectedness in our system. Yes, it's improved over the last 10 years, but it's still pretty terrible. And we have no connectivity between our health system and our public health system. And both are intrinsically fragmented, and they both are not connected with each other. There was an informative study to me done by Hopkins and published in 2019. It was done in collaboration with a couple of other organizations. And it was, the topic was, I think it came out in November of 2019. And the topic was, what countries are best prepared for a pandemic? And they had, 35 criteria in various aggregates. And the United States was #1 as the best prepared country. And it turned out we were terrible. And so you look at things that were in that were highly ranked, and they included things like connection of public health with the health system interconnectedness, the political sense that there was not a politicization around health. So these are the things that we were not listed great at, but probably ended up being the most important things. And they all have to do with systems. We're thinking of this in our own work. So if you look at those companies of Health 2047, we're now mapping them and saying, okay, what's the white space between these two companies? How do we fill that? Is there a venture in there? And so we can start building up more system solutions as well. But you're absolutely right in your impression.
Dr. Wolf.
Hi, Jim. Mike Wolf. So
Mike.
just to go expand on Dr. Weiss's question, as a former chair of medicine, it was very frustrating to see the lack of remuneration, not just for primary care, but for non-procedure oriented subspecialists. And part of the problem is it seems that the payers seem to value the motor cortex over cognitive services. And it's, if you look at the RVUs that are allocated toward procedures, they're just way, way out of proportion to what people get for thinking. And that could be remedied fairly quickly by just changing the allocation of RVUs. Is there any way that's going to happen in the near future?
Yeah, well, that has happened to a small degree with the E&M codes that were developed and these other changes that we've instituted that have been accepted by CMS. I would say both populations are unhappy. From primary care, it's not enough. And from specialty services is, why do we have to pay for them? You know, because right now the reimbursement through Medicare is a zero-sum game. And that's one of the conversations we're having with, the reimbursement for Medicare took a different legislative path years ago than the reimbursement for hospitals. And that's why you have that flat reimbursement over the last 20 years for physicians, but a hospital reimbursement that tracks with the CPI. We now have, with the doc caucus that we've just met with again recently, I think there's a bipartisan sense that, you know, they're willing to participate in this conversation and try to get us out of this dilemma. You know, that chart showing hospitals going like this and physicians going like that over 20 years has an effect on their opinions. I'd say the downside, Mike, is we really have a fractured political process right now that within the next couple of months is going to be totally shifted to a year and a half from now in the next election. So it's, you know, it's the truth of what we're dealing with, but we have some champions, I think, in Congress that have, you know, physician backgrounds.
Maria.
Jim, I should know this. The AMA has a PAC.
Yes.
And so, and so therefore you can only give money if you're a member of the AMA.
Yeah, so it's you know, let me say something about the PAC. It's
Maybe
It's a-
define what the PAC is, because it's a
Okay,
physician advocacy thing, but maybe define it better, because I'm not sure everybody on the call knows what it is.
okay, it's a political action committee, and it's a committee that makes independent decisions around you know, financial support for folks running for Congress and the Senate. Before the decision by the Supreme Court that allowed the recognition of companies being people, I mean, that's essentially what it said. Organizations like ours have very little financial impact because of the size of the dollars in the PACs. Having said that, we get noticed even when we write small checks. And we do that in a bipartisan way. And we do that tilted toward individuals that have interests that are in Congress and the Senate, align with those things we're trying to get accomplished. I spent the talk outlining. Now, when one has a PAC, you also can't be puritanical about it. So, you know, there will be people who get PAC checks who have aligned with what physicians would want 80% of the time, but 20% of the time did things that, you know, a lot of people would object to. And if you have an 80-20 win, you have to take it. You know, it's never going to be 100-0. So we do have a PAC, and it has that kind of functionality about it. Those decisions as to who